What are the top medications sold in the U.S. and why you need to know? Although chiropractors don't prescribe medication, it would be naive to think that medications are not part of our practice. Our patients often are self-medicating with over-the-counter medications or have received a prescription from an MD prior to seeing us. Several questions then arise that will be the focus of this presentation. It would be impossible to know all drugs sold and potentially taken by our patients, but there are statistics that can narrow down this list to perhaps 20 to 30 medications based on the following. What are the top grossing drugs in the U.S., and what are the top selling drugs in the U.S., not necessarily the same list. It's important to then know what they're used for and what the top concerns are for each classification of drug. And realizing that although we cannot unprescribe, educate patients to reasonable alternatives, if any exist, and perhaps, if the patient is interested in an alternative, have them then have that discussion with their prescribing MD. Let's start with some eye-opening statistics from the IMS Institute for Healthcare Informatics. Patients in the U.S. spent $307 billion on prescription drugs in 2010, an increase of 2.4% in 1 year. Interestingly, the number of prescriptions increased at a little more than 1% last year, and yet the number of visits to healthcare providers by patients decreased 4%. This might imply more prescriptions per visit, or perhaps some prescriptions without a visit. Did you know that generics now make up 78% of total prescriptions, up 15% from just 4 years ago, and this trend is likely to increase as patents on some of the most popular drugs run out? Of course, what then often happens is an over-the-counter version of a drug that used to require a prescription. This is usually at a lower dosage, but increasing the number of pills taken negates that effect. Recent statistics are alarming. The CDC's National Center for Health Statistics published in 2011 a survey related to medication usage from 1999 to 2008. You can see the gradual increase, but what is most alarming is the use of 5 or more drugs, which increased from 6.3% to 10.7%. Now look at that same statistic by age. When surveyed for drugs used in the past month, 36.7% of those 60 and older took 5 or more drugs. Simply looking at the use of one drug in the age range of 12 to 19 indicated on average about 30% of U.S. youths answering yes. Look at the use of at least one prescription drug for those 60 and over. It's an incredible 88.4%. It's hard to believe that from a society that a century earlier used basically no real medications, that this is entirely necessary. Let's start with a list of the top money-making medications. The total gross sales for only the top 10 was for 2010, $48 billion, for an average of close to $5 billion for each drug. Here's the list. Lipitor, Nexium, Plavix, Advair, Abilify, Seroquel, Singulair, Crestor, Actos, Epigen, Remicade, Enbrel, Cymbalta, Avastin, and OxyContin. I would imagine you're not familiar with many of these, although many are frequent stars of commercial breaks on TV. So what are they used for? For diabetes, Actos. For high cholesterol, Lipitor and Crestor. For asthma, Advair and Singulair. For manic depression and sometimes schizophrenia, Abilify and Seroquel. For rheumatoid diseases, Remicade and Enbrel. For GERD, Nexium. For pain, OxyContin. For production of new red blood cells in cancer patients, Epigen. And for treatment of some cancers, Avastin. Now, let's look at the most prescribed drugs and then compare these to the top grossing drugs with regard to when their intended uses overlap. Here they are: Vicodin, Zocor, Lisinopril, Synthroid, Norvasc, Prilosec, Zithromax, Amoxicillin, Glucophage, hydrochlorothiazide, Xanax, Lipitor, and some runners-up: furosemide, Lopressor, and Ambien. And what are these drugs used for? For diabetes, Glucophage. For high cholesterol and indirectly cardiovascular risk, Zocor and Lipitor. For infection, Zithromax and Amoxicillin. For hypertension, Lisinopril, Norvasc, hydrochlorothiazide, furosemide, and Lopressor. For GERD, Prilosec. For pain, Vicodin. Thyroid disorders, Synthroid. For unipolar depression, Ambien. And for anxiety, Xanax. Now, let's look at what is unique between these two groupings of medications and what overlaps. Here are the conditions managed for the most profitable meds. They are bipolar depression, rheumatoid disorders, asthma, cancer, and chronic kidney failure. For the most prescribed drugs, it's hypertension, infection, thyroid disorders, and unipolar depression. Here are conditions managed that overlap between the two categories: pain, diabetes, high cholesterol, and GERD. So what's so interesting, and why make the comparison? Lifestyle modification. All of these overlaps are potentially manageable with lifestyle modification. For all the conditions managed, let's look at which are and are not modifiable through lifestyle. Modifiable are diabetes, high cholesterol, GERD, hypertension, and chronic pain, and to a lesser degree asthma, depression, and rheumatoid disorders. Not modifiable after having the disorder are thyroid disorders, chronic renal failure, and cancer. Now look at the impact when we look at how the use of medication is spread out across age groups and percentages with regard to use. The clearest impact would be on those 60 and older, where 90% of drugs are used to reduce blood pressure and cholesterol and treat heart disease. By simply doing three things: exercise, eating a healthy diet, and quit smoking, most of these top-grossing, most popular drugs are not necessary if the disease is prevented, or are less necessary after having a disease in many, many cases. We'll now take a look at some of these medication classifications to see what their mechanisms of actions are, and any concerns, and any possible alternatives evident in the literature. Let's start with a classification of drugs that is often in the top two: statins. On our list were Lipitor, Zocor, and Crestor. The proposed mechanism of action is that the statins are inhibitors of HMG coenzyme A, which results in decreased liver synthesis of cholesterol, primarily LDL cholesterol, and upregulation of LDL receptors, resulting in an uptake of LDL, making them less available for atherosclerotic clot formation. Here's a recent study that appeared in many newspapers. Crestor was touted as being able to reduce MI by 55%, stroke by 48%, and angioplasty by 45%. Well, let's look at some specifics based on, in particular, the absolute risk reduction and the numbers needed to treat. Understand that Crestor is a major moneymaker with annual sales of over $4.5 billion. This was a study used to decide whether to extend the approved use for those prescribed Crestor by including the following: if patients were male and over 50 or female and over 60, and if you had one major risk factor such as smoking, hypertension, or an elevated C-reactive protein. Interestingly, the author and primary investigator was the developer of the CRP test. Before we get to the numbers, know that this was a comparison to no drug, placebo. Now the numbers. For the placebo group, major ischemic events occurred in only 0.37%. Yes, that's right, 0.37%. In the Crestor-treated group, the event rate was 0.17%. Subtract the two event rates and you get the absolute risk reduction of 0.2%, not even half of 1%. The inverse of this is the numbers needed to treat, 1 divided by 0.2, and you get 500. An NNT of 500 means you would need to treat 500 people compared to no treatment to avoid one myocardial infarction. And by the way, that would cost over $600,000 per year to avoid one event, and this is the cost only for 500 patients taking the drug. Another potential issue with statins is an increased risk of diabetes. In this recent study entitled Statins and the Risk of New-Onset Diabetes, published in 2011, they concluded that impaired peripheral insulin signaling induced by statin therapy may increase diabetes risk. In this meta-analysis, for every 3 patients protected from a major cardiovascular event, 1 additional patient developed diabetes. An interesting side note. Statins are suspected of decreasing levels of L-arginine and coenzyme Q to the point where some doctors are recommending supplementation, in particular of coenzyme Q, in an attempt to prevent the muscle soreness reported with statin use. L-arginine is the precursor to nitric oxide, essential to maintaining vascular tone, decreasing vascular resistance. Coenzyme Q preserves nitric oxide, preventing its degradation. Foods high in L-arginine include brown rice, chocolate, and caffeine. Other foods might make a good breakfast, including oatmeal, raisins, nuts, and whole wheat bread. Combine with a banana and you have the added benefit of potassium. Coenzyme Q is found in meats, vegetable oils, broccoli, cauliflower, and parsley. As a supplement, it is best absorbed as a chewable tablet eaten with fat-containing foods. Now on to Plavix, clopidogrel. Plavix irreversibly inhibits an ADP receptor subtype necessary for platelet aggregation and cross-linking of fibrin, preventing clot formation. It's a prodrug activated only after metabolism via the cytochrome P450 system, so it's not to be used with proton pump inhibitors. A fairly recent research study compared the reduction of ischemic events in patients using the new approach of Plavix versus the standard tried-and-true antiplatelet aspirin. It was indicated in the study that the improvement using Plavix versus aspirin was 8.7%, a small number, but possibly significant given the seriousness of the outcome of ischemic events, which include MI, stroke, or vascular death. It turns out that the ischemic event rate in the aspirin-treated group was only 5.83%, and in the Plavix group it was 5.32%. That does work out to an 8.7% advantage for Plavix if calculated as a relative risk reduction. But now, subtract the event rates in both groups. This equals only 0.51%, about half of 1% advantage over aspirin. The number needed to treat is 196. It means you would need to treat 196 patients with Plavix to avoid 1 adverse event compared to aspirin. Considering the cost of this new drug versus aspirin, do you think that this is a logical choice to switch to this new treatment? Well, many patients have, and that's why it's in the top 10. Now, proton pump inhibitors, or PPIs. On our list were Nexium and Prilosec. PPIs block the hydrogen-potassium ATPase enzyme system, more commonly called the gastric proton pump, effectively blocking parietal cell production of hydrochloric acid by 99%. Hydrochloric acid, though, is required for the digestion of proteins and absorption of vitamin B12 and calcium. These two drugs are not the same. When comparing Nexium to Prilosec, both are approved for duodenal ulcers due to H. pylori, gastric ulcers, and GERD. But for Nexium, it's not approved for duodenal ulcers due to other causes and not approved for gastric ulcers from causes other than NSAIDs. And it's also approved only for adults. One of the top concerns with PPIs is osteoporosis. Observational studies have shown an association between long-term PPI use and fractures of both the hip and vertebra. The mechanism appears to be achlorhydria, leading to malabsorption, and calcium and vitamin B12 deficiencies resulting in bone loss. These drugs are very popular and have recently come under attack by the medical profession as being overprescribed. In 2008, a British medical journal editorial made the accusation of doctors massively overprescribing proton pump inhibitors. The accusation was that between 25 to 70% of individuals on these medications have, quote, no appropriate indication to be taking them. Another concern is prescribing Prilosec for infants and children. Physicians prescribe acid-suppressing drugs for frequent spitting up, irritability, and unexplained crying in infants. Also, there was a 39% greater risk of having children with birth defects for women who took the medications 4 weeks prior to pregnancy. This study looked at nearly 841,000 births registered with national databases from 1996 to 2008. In 2011, in the Journal of Pediatrics, an editorial commentary concluded, "We are medicalizing normality. In most infants, these symptoms are life, not a disease, and do not warrant treatment with drugs, which can have significant adverse effects." Are there risks for infants and children? Well, gastric acid is a first line of defense against infection. As a result, infants given PPIs may be at a higher risk for pneumonia and gastroenteritis. The use of PPIs in infants and children can also lead to abnormalities in the level of essential minerals and vitamins such as magnesium, calcium, and vitamin B12. Now on to antidepressants. On our list were Cymbalta, Abilify, and Seroquel. Abilify is a partial agonist for dopamine and serotonin receptors. Cymbalta acts as a serotonin and norepinephrine reuptake inhibitor. Seroquel acts as a dopamine type 2 and serotonin type 2 receptor antagonist. It may seem that the actions of these drugs are counter to each other, but remember that some of these are used for the manic phase of bipolar depression. Starting with exercise, the evidence is fairly strong that continued exercise can be as effective as psychotherapy, which is as effective as pharmaceutical approaches, at least for mild to moderate depression. It doesn't seem to matter what type of exercise, but more the commitment to regular exercise. Some obvious benefits are increases in serotonin and endorphins, but also improvements in self-esteem. A recent Cochrane review came to similar conclusions, but as usual, the researchers would like to see more higher quality studies. The evidence also suggests that the combination of exercise and medication is better than exercise alone. However, exercise may be more robust in that it can better maintain the therapeutic effect. In the Journal of Clinical Psychiatry, an article published in 2011 demonstrated that patients randomized to an exercise group instead of a group where an additional medication was prescribed did just as well. Now, herbs and supplements. The first consideration is there are potential co-effects using these options with medication that may potentiate or decrease the medication's effectiveness. Never use these as primary management, and always, when used, do so with the knowledge and approval of the prescribing MD. We'll give a brief overview for each. For tryptophan and 5-HTP, a Cochrane review indicated that tryptophan and 5-HTP were better than placebo in the treatment of depression. They expressed some concerns about past toxic issues regarding eosinophilia myalgia syndrome. A contaminant known as peak X was found in several commercially available tryptophan products several years ago. Check the process used by the company to determine the purity of the product and whether they are peak X free. According to a Cochrane review, the evidence suggests that hypericum extracts are superior to placebo for major depression and similar to antidepressants. Interestingly, one study compared St. John's wort, sertraline, and SSRI and placebo. Look at the results. Placebo beat hypericum in this study and was almost equal to the SSRI. This should remind us that the placebo effect for depressed patients is high, regardless of whether a medication or supplemental product is used. For omega-3 fatty acids, the evidence in a Cochrane review indicated some effect for the depressive phase of bipolar disorders, but not for the manic phase. A study in the American Journal of Psychiatry indicated that the addition of omega-3s to maintenance medication treatment is an effective adjunct. Another Cochrane review found that depressed patients given folate had reduction in their symptoms, and in one of the review studies was equally effective as trazodone, an antidepressant. Now, diabetes medications. On our list were Actos and glucophage or metformin. The mechanism for Actos is that it reduces insulin resistance in the liver and muscle and decreases serum glucose and glycosylation. Glucophage or metformin reduces gluconeogenesis in the liver, reducing LDL cholesterol and triglycerides, and increasing insulin receptor sensitivity. A monumental study by the Diabetes Prevention Program Research Group compared the effect of lifestyle versus metformin versus placebo in the reduction of incidence of type 2 diabetes. The reduction of the incidence of diabetes was 58% for those on the lifestyle intervention, compared to only 31% for those using metformin. The researchers concluded that a Western dietary pattern high in red meat, fat, refined grains, and sweets and desserts, combined with low physical activity or obesity, substantially increase the risk of type 2 diabetes compared to a prudent dietary pattern, one that included the consumption of vegetables, fruit, fish, poultry, and whole grains. Let's move on to exercise. One study indicated that if diabetic patients were convinced to walk 2 hours per week, the rate of death would decrease by 1 per year for every 61 people who walked. In another study, the benefits of walking were also demonstrated with women who performed an 8-week walking program of 10,000 steps per day, with benefits of improved glucose tolerance and a reduction in blood pressure. There are many other studies showing similar results. Many systematic reviews have addressed the issues of whether caffeine, and specifically coffee, is harmful or beneficial to diabetics. Actually, caffeine may have negative effects. However, chronic high intake of coffee, and in some studies tea, have been shown to decrease the risk of diabetes. Other studies also have shown an inverse relationship between high coffee consumption and diabetes. Be careful that caffeine and coffee are not equal here, because in some studies decaf coffee also works. Coffee contains antioxidants and specifically chlorogenic acid. Another study indicates that timing may be important. The study indicated that drinking coffee at lunch had the biggest effect. Now, antihypertensives. On our list were lisinopril, hydrochlorothiazide, and Norvasc. Lisinopril is an ACE inhibitor. They block the conversion of angiotensin 1 to angiotensin 2, breaking the cycle that would include aldosterone release. Thiazide diuretics reduce sodium reabsorption in the distal convoluted tubule. Calcium channel blockers block calcium channels, decreasing peripheral resistance from smooth muscle constriction of small blood vessels. Lisinopril, an ACE inhibitor, has a common side effect of a dry, non-productive cough. Now, cough is common, and it is important to time the onset with a prescription of an ACE inhibitor to determine if it is the cause. The dry cough associated with ACE inhibitors may be alleviated with iron supplementation, but not at the same time due to potential interference with the drug's absorption. Lasix is a diuretic. Some possible important side effects are that, similar to all loop diuretics, it may cause hypokalemia or low potassium levels. Newer drugs may include potassium, such as Lasix-K, or combine with a potassium-sparing diuretic. Lasix may reduce the production of coenzyme Q, and also may cause loss of magnesium. So what are conservative options for hypertension? Well, they fall into several categories, including weight loss, general dietary approaches, stress relaxation, increases in potassium, decreases in sodium and alcohol intake, and exercise. Specifically, the JNC guideline publication that established categories for hypertension also suggested treatment guidelines. These seem hidden to many healthcare providers. The focus seems more on medication usage. Here we can see the effect for each of these on systolic blood pressure based on the literature. Just a point of clarification, DASH stands for Dietary Approaches to Stop Hypertension. It is basically a healthy diet made up of fruits, vegetables, some grains, decreased sodium, and low fat. It's available online and as a free basic outline, or also as a book with recipes. Considering the effect of antihypertensive medications on average, lifestyle approaches, although difficult, are as effective as even a 2-drug antihypertensive regimen. In addition to factors listed in the JNC guidelines, several recent publications indicate that a prescription of slow breathing of 6 to 10 breaths per minute for 15 minutes every day is a significant antihypertensive approach. Potassium has emerged as an important factor. Only 1% of individuals in isolated societies, compared to 33% of those in industrialized countries, have hypertension. One clear difference is the amount of naturally occurring potassium in the foods ingested. Potassium depletion initiates a process where cells take in more sodium in order to maintain volume and tone. Also, low potassium inhibits insulin secretion and causes glucose intolerance, making diabetes worse. The recommendation from the Institutes of Medicine is actually twice the U.S. average intake of potassium. Several studies have looked at the effect of increasing potassium either through foods rich in potassium or supplementation. In one, 82% of individuals needed less than half of their medication dosage, and 38% required no medication even after 1 year follow-up. Foods high in potassium include cantaloupe, bananas, tomatoes, cucumbers, papaya, lima beans, and plantain. Now, asthma and COPD medications. On our list were Singulair and Advair. Singulair is a leukotriene receptor antagonist. By inhibiting 5-lipoxygenase, an enzyme of the eicosanoid synthesis pathway, it blocks some of the inflammatory reaction. Advair is a combination of fluticasone and salmeterol, which is a combination of corticosteroid and a beta-2 agonist, respectively. This reduces inflammation and assists with bronchodilation. For Advair, the combined inhaled corticosteroid and beta-2 agonist, it's important to know that this may cause oral candidiasis. Less often, it causes osteoporosis. For beta-2 agonists, there is the risk of increased blood pressure, change in heart rate, an irregular heartbeat, and the risk of asthma-related death. For children, tremor, hyperactivity, and lack of appetite are also common. One major group of medications we did not discuss were those used for pain management. We'll devote a separate entire presentation to this topic. Hopefully, this brief presentation has summarized for you the major classifications of medications that your patients are likely taking. It's crucial that we understand these medications enough to recognize possible side effects that may change a patient presentation or response to care, and also to understand that the majority of these medications are for conditions that can be prevented or controlled through lifestyle modification.